ventilation and diffusion, COPD, chronic obstructive pulmonary disease. Obstructive lung disease is a problem of ventilation. Obstruction blocks the ventilation. Now there's three basic categories here. The first one is mechanical obstruction of the airways. That can be from foreign bodies, tumors, or chronic mucus plugging that occurs in chronic bronchitis. The second is increased resistance in the airways. Examples here are airway thickening from chronic inflammation, again, in chronic bronchitis. And the third type is increased tendency for airway closure. This is a component of both asthma and emphysema. All of these obstruct exhalation. The first one we're going to look at is emphysema. Here is a view of what emphysema is going to do to the alveoli. In emphysema, there are weakened and collapsed air sacs, weakened or collapsed alveoli with lots of mucus in them. Emphysema is an irreversible enlargement of the air spaces in the alveoli. There's destruction of the alveolar walls and obstruction of the airflow. Chronic smoking is most often implicated in the development of emphysema. Normally, there are a lot of alveoli, and they are small, tight sacs. In emphysema, the destruction of the alveolar walls creates fewer, bigger, and floppier alveoli. The alveoli and bronchioles have a weaker elastic recoil, so they're more likely to collapse. They can't expel air as readily. That makes it hard for the air to get out, so air is trapped, and we have hyperinflation of the alveoli. Now, while emphysema is primarily a problem of obstruction, a problem of ventilation, because of the damage done to the alveoli, there's less surface area for diffusion to occur. So yes, there's some diffusion issues, but basically this is a problem of ventilation. We see a persistent cough, dyspnea, wheezing, barrel chest, and pursed lip breathing. What we're going to do for these folks is help them to optimize their lung functions so that they can live as independently as possible, so that they can do their own ADLs, or activities of daily living. We're going to help them to stop smoking. We're going to provide medication, and that's probably going to include oxygen. And sometimes we are looking at taking out lobes of the lung or actually doing a transplant of the lung. Chronic bronchitis. It's a persistent, productive cough lasting 3 months or greater for 2 or more consecutive years. And it is a result of chronic inflammation and edema in the airways. We're talking the bronchial tissue here. There's hyperplasia of the bronchial tissues and destruction of the cilia that are along the bronchial tissues. There's squamous cell metaplasia and bronchial wall thickening and the development of fibrosis. With chronic bronchitis, we're going to see a person with a cough who has purulent sputum. They're going to have dyspnea, and they're going to have adventitious lung sounds. We're also going to see cyanosis. Again, we're going to encourage them and help them to stop smoking. The pulmonary rehabilitation is helping them to learn how to breathe, how to maximize their own lung functioning. We're probably going to be introducing medications and oxygen. Okay, asthma. It's intermittent or persistent airway obstruction. Quite often, it's because of allergens in the environment, but again, we often don't know what is causing it in an individual. It is characterized by bronchial hyperresponsiveness. That means the level of allergen has to be quite low in order for the bronchioles to over-respond. You know, what would normally cause a little response in a normal person will cause a big response in someone with asthma. There's bronchial constriction, inflammation, and excess mucus production. And we have triggers for asthma attacks. They're allergens, or it may be an environmental trigger such as smoke, dust, dust mites, mold, or animal hair. Some people have a trigger of exercise. They start to exercise, they start to have an asthma attack. Temperature extremes. They go out into the real cold or real hot weather, they tend to get an attack. Illness or anxiety will also trigger an attack. When the allergen or trigger hits the bronchial tissues, they do two things. They release mast cells and they go into bronchospasm. The mast cells release histamines, prostaglandins, and trigger the inflammatory process. The inflammatory process results in edema, excessive mucus production, and ultimately epithelial injury. The mast cells also cause further bronchospasm, which decreases airflow, especially the airflow going out. It's hard to exhale. So we're going to end up with wheezing and dyspnea. The alveolar ducts and the alveoli remain open, but the airflow into and out of them is obstructed, so air is trapped inside. We'll see the wheezing and tachypnea, dyspnea and coughing, chest tightness, excessive sputum production, and anxiety. We're going to monitor lung function, control the environmental triggers, offer them medication, and help the patient and their family to come up with their own plan of how to avoid the triggers, how to restructure the household, their activities, that kind of thing. The main difference between asthma and COPD is that the bronchoconstriction in asthma is reversible. Now there is a very serious type of asthma, that's status asthmaticus, and it's a long, prolonged asthma attack that doesn't go away when they use their typical drug therapy. It may last several minutes to hours, and it is an absolute medical emergency, which can cause death if a person doesn't get proper treatment.